Good morning, honorable judges and my fellow participants and everyone present here. I am Dr. Sangeeta Mandal, junior resident in the Department of ENT, would like to present a paper on study of foreign body in aerodigestive tract in a tertiary care center. When we talk about ENT emergencies, aerodigestive foreign bodies are the most common and if especially in pediatric population can be potentially threatening and are commonly seen in hospital emergencies. Identification of these foreign bodies can be challenging and imaging plays a crucial role. My aim and objectives are to study clinical presentation, management and complication of these foreign bodies in aerodigestive tract. It is a prospective observation and interventional study which was done on the patients attending ENT OPD and the casualty in a tertiary care center fulfilling my study criteria, and it was done for about 24 months on 50 subjects. All the patients with or without the history of foreign body ingestion and aspiration, which was confirmed on clinical examination and investigation, and the patients willing for the study were included in my criteria. And the patients with the foreign bodies below the lower end of esophagus and in nasal cavity and nasopharynx, and the patients with history of ingestion and aspiration, which was not confirmed on clinical examination and investigation and were not willing for any intervention were excluded from my study. Thorough history taking was done for any history of foreign body ingestion or aspiration from the relatives and the patients and or any other ENT complaints, followed by clinical examination including general local ENT examination and indirect laryngoscopy or video laryngoscopy if required. Investigations like X-ray neck epilateral and high-resolution computer tomography of chest and non-contrast computer tomography of neck was done, followed by management in which surgical management was the mainstay treatment. Some of the common foreign bodies encountered in aerodigestive tract during these studies were, starting with digestive tract, coin, chicken bone, mutton bone, fish bone were commonly seen and removed. Part of toys and even food bowls and part of dentures and sharp foreign bodies like safety pins were also removed, as you can see in these pictures. And then coming to airway tract, groundnut pieces was most common and other organic foreign bodies like custard apple and tamarind seed were also removed. Sharp foreign bodies like safety pin and scarf pin were also removed, and part of toys were also seen and visualized and removed. Coming to radiological investigation, as you can see in the first picture, in a anterior-posterior view, around a circular radio-opaque foreign object can be seen in the neck, followed by in lateral view, a slit-like radio-opaque object can be seen, which is behind the air column, which is suggestive of foreign body in esophagus. Coming to other set of images, the first image showing radio-opaque object in the air column. Similarly, a slender-like radio-opaque object can be seen in anterior-posterior view and lateral view, suggestive of foreign body in trachea. Coming to the next set of images, a foreign radio-opaque object can be seen in right bronchus and the left bronchus, and even in lower part of the airway, suggestive of foreign body in bronchus. Coming to observation and results, the cases in which airway foreign body was seen was predominant in age group 0 to 2 years of age, followed by 2 to 3 years of age. And whereas in digestive tract foreign body cases, it was seen in 6 to 7 years of age, followed by 5 to 6 years of age, and in some cases, more than 50 years of age group was also seen. The most common presenting complaint in case of digestive tract foreign body, it was dysphagia and odynophagia, and in some cases, foreign body sensation and vomiting was also seen. Coming to airway tract foreign bodies, in 30% of the cases, cough was seen in form of bouts, and stridor was seen in around 25% of the cases. In some cases, wheeze and dyspnea was also seen. Coming to complication due to foreign body, when we talk about digestive tract foreign body, the most common complication was mucosal erosion, which was seen in around 20% of the cases, followed by mucosal bleeding, which was seen around 15% of cases. Perforation wasn't seen in any of the cases. When we talk about airway tract foreign body, in that around 45% of the cases, we saw bronchopneumonia as the common complication due to foreign body, followed by atelectasis, which was seen in around 25 cases, and in around 7% cases, pneumothorax was also seen. Coming to the management, most of the digestive tract foreign body were removed using esophagoscopy, as we can see in this video showing esophagoscopic removal of foreign body coin. This is a picture showing telescopic visualization of foreign body in esophagoscopy, and this is the picture after removal of the foreign body. Some of the cases were also removed using Magel's forceps pyriform fossa and cricopharynx, and some using angular forceps in postpharyngeal wall and tonsillar fossa. Coming to airway tract foreign body, the foreign body cases in airways underwent diagnostic and interventional scopies in which bronchoscopy was used for all the foreign bodies, whether it was in bronchus or trachea. As shown in this video, showing bronchoscopic removal of an organic foreign body, custard apple seed, and this is after the removal of the foreign body. This video shows telescopic visualization of a sharp foreign body pin in right bronchus, as you can see. The incidence of the foreign body in digestive tract was most commonly seen in 6 to 7 years of age, around 50% of the cases, which was similar to other studies like HARKUT et al. Studies. And coming to the most common complaint, it was dysphagia in around 60% of the cases, which was also seen in Anupam Mishra et al. Study. Coming to the type of foreign body, currency coins were seen in around 50% of the cases, and it was similar to other two studies like HARKUT et al. And Jaffet et al. Study. And it was most commonly found in esophagus in around 55% of the cases, followed by cricopharynx, and it was similar to other studies like HARKUT et al. And PSN Murthy. Incidence of foreign bodies in airway was most commonly seen in 0 to 2 years of age, which was also similar in HARKUT et al. Studies. And groundnut was seen in around 50% of the cases, which was also similar to HARKUT et al. And Jaffet et al. Studies. Coming to the presenting complaint, cough was seen in 30% of the cases, which was in contrast to other studies, like in Anupam Mishra, predominant symptom was dyspnea, and in Banerjee it was choking. And 80% of the cases were found in right main bronchus, which was similar to other studies. Foreign bodies in aerodigestive tract continues to be diagnostic and therapeutic challenge for otorhinolaryngologists. Symptoms of this foreign body in aerodigestive tract, mainly non-specific and high precision is required, and experience and clinical acumen is required. History taking and physical examination remains the cornerstone assessment of the patients. The final conclusion is that these foreign bodies in aerodigestive tract does not possess any serious problem as highlighted in the previous study, provided they are managed timely and appropriately in trained and experienced hand. Thank you.
What do you think to be the reason why the foreign bodies are more common in children?
The children is basically common because they are many times ignored, and they don't give any history of foreign bodies, and they are likely to ingest a foreign body, and even they have a high respiratory rate, and because of the age group and because they don't develop the swallow reflex properly in that age group, and that's why it is seen in lower.
Okay. You mentioned as a complication bronchopneumonia,
Yes.
35% cases. So which type of foreign bodies in bronchus you think that they cause more bronchopneumonia?
As we have seen, in 50% of the cases, groundnut was seen, and because of the consistency of the groundnut, the oily nature of the groundnut, it causes chemical reaction. Because of that, infection occurs and bronchopneumonia leads to bronchopneumonia.
Thank you.
What
Okay.
do you do for this open safety pin?
Sir, we actually removed using bronchoscopy. It was open pin, and the tip of the pin was into the mucosa of the trachea, and we held the tip of the mucosa and removed from the mucosa, and then either we can close it and remove the safety pin, but it was not possible. It was bent, so we removed the tip from the mucosa, and then we removed it through bronchoscopy from trachea.